Hello, everyone. Thanks for joining today's session, How Interoperability and Price Transparency Rules Enable Informed Decision-Making and Patient-Centered Care. This webinar is sponsored by RX Review. RX Review is on a mission to improve healthcare by providing accurate, patient-specific coverage and cost data at the point of care. RX Review solutions help clinicians quickly and easily find affordable options specific to a patient's health and financial needs. With comprehensive, clinically relevant information at their fingertips, clinicians can make more informed, consistent, and frictionless care decisions. For more information about RX Review, its innovative solutions, and growing network, please visit rxreview.com. I'm Sean Edwards from World Congress and Validation Institute. I will be introducing our webinar today. Just a couple of quick logistical items before we get started here. As an attendee, you will be in listen mode. So I'd like to discuss how we're going to handle questions. If you could submit your questions for the speakers at any time via the Q&A feature that you see at the bottom of your screen, that would be super helpful for us. We'll answer all questions that we have time to address during our session today. And finally, please note the webinar will be recorded. You'll receive a link to the webinar so that you can view it again. I'd like to introduce our speakers for today now. Kyle Kaiser is the President and Chief Strategy Officer at RX Review. Anish Chopra is the President at Care Journey. And Joel White is the President at Horizon Government Affairs. Gentlemen, thanks for being here. Without further ado, I'm going to turn things over to Kyle, our moderator.
Great, thank you for the intro, and appreciative to have Anish and Joel with us today. We're eager to have this discussion. There's been a lot of activity on the topic, and I think this will be a great opportunity to discuss some of the details together and how we're going to turn this into progress and reality in the industry. So before we get started, we'd love to know, rather than another Zoom call into a faceless group, we'd love to know a little bit about you and tell us who's on the line, share more about who you are, and that'll sort of help inform our discussion to some degree. I think we're getting results in. Good. Well, it looks like we have a good mix of people on the line today. This should be a good discussion, a good mix of provider, payer PBM, manufacturers, and policy and technology folks, which is great. That's exactly the mix of people we need to get things done. So eager to have the discussion. So our hope for today is really to talk about the activity that's happened in recent history. There's been quite a bit of it in the last several months, and really, kind of have a tangible conversation about what are the impacts of these new rules and regulations and policies. How do we turn them into action, and how do we turn them into something that can actually move the industry in the right direction, and what environment is out there to implement them. Maybe what headwinds are ahead of them as well. And then spend a little bit of time on kind of a success story around when this has worked well and how we've seen this kind of go in a really positive direction. And then have a healthy discussion on sort of what's it take to move this stuff forward. Sort of, there's always a process along this, and happy to have two experts in that regard on the phone with us today. And then have a good Q&A. That's the hope for today. Sound good? Good way to spend time, fellas?
Let's do it.
Yeah. Well, let's dig into it. I think that, historically, that to really sort of understand where the industry's been, right, is patients have a lot of headwinds to figuring out how to make good care decisions. Sometimes those are purchasing decisions. Sometimes those are just trying to get access to the care that they need, right? And the way that the world often works today is because there are significant barriers between that patient's information, that patient's data, the regulations around payment often, or benefit design, or the sort of links between those things, and technology vendors, that it feels like sometimes it's the patient's responsibility to mitigate that risk for themselves, to sort of search in the wilderness to find their own answers. And that's really just the realities of where we are today. Really, it's well-meaning, well-intentioned companies that are sort of operating within their own silos, in a lot of ways are prevented from trying to solve specific patient-centered problems. And so ideally, good policy, good technology, and good data access puts the patient at the center of that experience. The goal is to make it easy for the physicians that serve those patients, for the patients that need that care, to do the next thing that's important on their care journey. And I think when this works well, it's the technology, the data, and the policy efforts sort of overlap in ways that allow patients access to their data, patients access to the data they need to drive their own payment discussions and decisions, and allows technology vendors to meet the mark on the needs that emerge from those new types of opportunities and competitive environments. So in an ideal world, that's what we're aiming for, right? Is to put the patient at the center of this story. Now, there's probably been more activity around data access and price transparency in the last 6 to 12 months than there has in the last 2 decades. Does that sound fair to you guys?
There's certainly a lot of enthusiasm. Real quick, Kyle, can we do a technical check? Can everyone else see the slides? I think there's a question that came up about whether that's coming through. Do we get a thumbs up from the crowd that they can see what you're broadcasting? Hopefully. Yes, perfect. All right, thank you. Sorry, Kyle.
Oh, you're good. Thanks for checking. So, ultimately, since 2020, there's been a flurry of activity around these efforts, right? It's driving patients' access to their own data, driving access to price transparency information, be that on the provider or the payer side, and then providing access to those types of data in meaningful ways that drive different decisions at the point of care in the case of real-time benefit or prior authorization. And all of that activity has been condensed in a relatively short time frame. So I think our hope for today was just to talk a little bit about what's out there, talk about the stakeholders involved in some of those new rules, what's ahead of them, what's going to work, what headwinds are out there, and have a sort of tangible discussion about all that's happened as a starting point. That sound good?
Oh, it sounds great.
Right. And I think, we could sort of maybe jump the gun on this slide a little bit, but ideally, right, when it works, new rules lead to new technologies that deliver value at scale that ultimately reduce the cost of healthcare, reduce the cost Medicare has to pay for patients, reduce the burden on the system, and make things happen more efficiently and make things happen in a way that allow people to get access to the care they need. So let's talk about what's happening around pricing. So there are several rules out here, some maybe more controversial than others, and maybe we should talk through these in detail. I guess as we look at the hospital price transparency rules that are now sort of a priority given the dates, what do you guys see out there so far? Is this something that hospitals are prepared to meet the mark on? Is it is it going to drive the types of activity that we hope for, or is this got some headwinds ahead of it?
Hey, Anish, I think, why don't I go first and maybe.
I was going to ask if you don't mind. I want you to tee it up because I'm ready to hit. I'm ready to hit.
Yeah, you do the gut punch.
Yeah.
So I think first of all, this came online January 1, and the hospitals had to have kind of standard charges ready to be posted and available to patients and consumers. These included things like cost of room and board, the use of facilities, facility rates. Any kind of, x-rays, gross charges, payer negotiated charges, discounted cash prices, minimum and maximum negotiated charges for each items, et cetera, for about 300 different items and services. And there were about 70 on the CMS side and 230 on the hospital side. And the goal here really was to provide some information to people so that they could, first of all, know what the price was, but also to be able to shop for services. And we know that, not all hospital services are shoppable, right? Like, you're not going to shop around for a good price on a heart attack bundle, but you might shop around for knee replacement or hip replacement or other more elective type procedures. And so the goal here really on all these pricing rules was to give some folks some upfront information so that they could be more informed consumers. And I can't think of a better way than saying, here's our price, and in the future, hopefully we'll get better quality and charitable care disclosure as well. But unfortunately, it seems that while hospitals might have been ready, they were not on board with actually going forward. So Anish, you want to take it from there?
Well, let me begin with some editorial comments about where the hospitals are, and then I'll rewind the tape to try to put this in context to tell everybody I'm quite bullish about where we're heading. So what I'm about to say is going to feel Debbie Downer, but I'm a happy optimist. And so let me kind of do the Debbie Downer and then I'll get to the optimist. In private conversations that I've had with health systems all over the country, there was a little bit of a, are we doing this? Should we just pay the penalty? Is anyone else doing this? Like, what's the industry going to do? And there's a lot of this, like, I think you'd call it, kind of a digital prisoner's dilemma, about like, who discloses and who doesn't. What I will tell you is that a couple things have really helped make the folks who say, let's skip doing this, or let's make this really hard to be useful, their defense wall is paper thin. And we saw this with the Wall Street Journal paper that came out, the article that came out about a week and a half ago, where, look, by definition, these rules are meant for local media to shame hospitals for failure to comply. That if you went on like a percentage of hits to the website, my presumption is that 80% are coming from media, not from consumer shoppers. A, they can't find them. That's the separate issue. But by and large, or I should say, that's not fair. Maybe a third from the media and maybe 2/3 from like tech vendors, like screen scraping for competitive intelligence, maybe. But for the most part, it is, everyone knew the media was coming, and every local newspaper and local media outlet ran stories on those who did publish the data. Inevitably, there was the gotcha moment where something looked silly, didn't make any sense, and sort of, having to explain the charge master and why these things are the way they are really hard. And the industry knows this has been hard to accomplish. And so that's why some people said, okay, I'll just sit back while others publish something and make it hard. But where I think this defense thin wall has come up is that somebody had the bright idea who said, let's publish the information, but let's proactively block the search engines from finding the data. Whoever thought that was a good idea should be put in media training jail, okay? Because you can't do that. Like, it is ludicrous to say that those prices are which are themselves gobbledygook, can't be accessible to machines. Machines are the ones that are going to interpret this for people. So the good news is when the reporters came in and said, by the way, we found that you wrote the code. You couldn't have stumbled into this by mistake. You had to actively write the code to block the search engines. They all dropped that restriction. Oh, technical glitch, mistake, issues, what have you, totally embarrassing. But paper thin, Joel, they didn't even defend themselves. 100% of the folks who were asked were like, who did that on IT? Those dumb IT people. I didn't, not me. I didn't do this. Now, let's not spend a lot of time on the negative. Let me lift, Kyle, do you indulge me for a few minutes? Can I be the happy guy now? That's okay. So let me be the happy guy now. Let me take a step back for a few minutes, and then I'll put all of these legislative activities in context. Number one, when the Obama administration began this journey to, kind of the $35 billion Recovery Act and, preparing for interoperability, we had sort of two technical challenges. Technical challenge number one, our private-led healthcare delivery system had no consistent or open source data model. Hence the gobbledygook. This is my charge master, Joel, that's your charge master. We don't have a common language. We have private vendors that do their own thing and they make their job. The second thing is we didn't have a mechanism. This thing called the internet hadn't showed up yet in the healthcare domain. So we didn't have a consistent method of transmitting this information. So we had a data model and a transmission method problem. The first thing we decided to do was to say, look, let's agree on a minimum data set that the entire industry has to sort out. And that minimum data set was not around prices or transparency. It was around basic clinical things, my vital signs, the medications that I'm on, the conditions that I have. It was a clinical data set. So you know where we're going, which is that, Congress and the administration is basically saying, year by year, step by step, we're going to be adding more and more to the open data model so we have a consistent view of the healthcare system. Then the next question was, we had all these enterprise technologies, how do I get my hospital and my doctor's office to connect? And we had all these kind of custom interfaces, and it was sort of this, a yesterday approach. The internet allowed us to make this, hyper fragmented delivery system connect like every fragmented website using internet protocols. So we are entering a moment, Kyle, the reason there's both a policy reason the last couple of years have been so attractive, but there's also a sort of a maturity of the technical strategy, which is ever-growing data model standardization and ever-growing use of internet-based standards to transmit the data. These two things, I think, are what give life to all of these rules. And I'll make the statement, and I think this is going to be a theme I'm going to carry out going forward. The false narrative is that the consumer with the Superman cape on is going to be logging into websites, figuring this all out and making sure that they get the best care at the lowest price. We know from every study how complicated it is to answer that question, even for something as simple as shopping for where to get an MRI. But where, Kyle, you may go as we get into the case study with real-time benefit check, inevitably there may be a trusted navigator, maybe the physician, who sees the price list with you in front of them and helps to make a decision about whether drug A or B is the right one for you with that feedback loop. And as we move to value-based care, there may be more of a care management function where your trusted physician network is assisting you even in the outpatient context to sort through this. Once the data is open, it's a clear open marketplace. Who will the consumers trust to use this information to make sure they get the best value care? So I'm bullish, not on the consumer with the Superman cape, but the trusted fiduciary, the trusted partner to help make sense of this. And so we're going to see bright days ahead of this information, and it may not be in the form we think it may be.
And it seems like, Anish, that the key to enabling that, and I totally agree, it's going to be sort of companies coming to meet really specific needs of their users that can help enable sort of better decision making at scale. Are the machine readable standards in both the hospital and health insurance requirements around this where they need to be to enable that, or did they stop short of sort of?
Yeah, so this is the part where I'm most, I live in the public-private interface. So CMS started by saying, can the industry self-organize? Joel said it right. We're going to name 70 really generic services, but you have 230 that you can define. Wearing my policy hat, I was like, hello, private sector, this is your chance. Standardize the options. Yep. Where's the committee of half a dozen CFOs to say, let's all agree when someone realistically is coming in for back surgery, it means this, 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 and this. Joel, did that happen?
No. No.
So before I get off my soapbox, let me get to the juicy piece. Do you see that third bullet here? No Surprises Act. I want to read from you, just if you'll indulge me for a minute, a passage from that bill, which basically takes the functional equivalent of a 2x4 to the industry to say, we need a standardized data model for price. And here's how it says the obligations are for every doctor starting January 1, 2022. Doctor, each healthcare provider and healthcare facility, hospital, shall provide a notification in clear and understandable language of something that CMS calls a good faith, Congress calls a good faith estimate of the expected charges. Now, here's the most important language. Quote, This good faith estimate includes any item or service that is reasonably expected to be provided in conjunction with such scheduled item or service, such as an item or service reasonably expected to be provided by another provider in the facility, an anesthesiologist for a procedure, preoperative testing, etc. Now, Joel, with this 2x4, Congress says this is not Trump, Obama, Biden. This is not partisan in that way. This is Congress. It's begging us to standardize the data model for prices. And Kyle, are you with me? Are we going to help bring this coalition to life so we can get the community to figure out what a good faith estimate is of reasonably expected services in conjunction? We can, and we shall. Joel, are you in with us?
I'm in. The interesting thing here, Anish, is that if you think about everything on this page happened 2020, right? And the No Surprises Act was one of the last things, right, that happened. And I think Congress got a little bit more sophisticated because they didn't just say like, release these discrete services or drugs or products or whatever. They said, what can a consumer reasonably expect? I mean, think about that language. It's not just I'm going in to get a Band-Aid from a hospital. I'm going in to get a suite of services in a bundle that I have to now figure out my cost sharing on versus my cost sharing on the Band-Aid and the aspirin and the surgeon's time and the operating room, et cetera. So it actually is trying to get to where the consumer's at, which makes the trusted fiduciary, or the navigator, as you call them, even more important, because they need to now put all that information into one place so that the consumer doesn't have to wear the cape. The consumer just needs to be present and making good decisions with or without a patient advocate. And so it really is getting to a much more sophisticated model. But I think what it relies on, and what we're getting to, Kyle, what you may get to, is that everything is going to depend on the data, and the data being accessible to these fiduciaries.
It's enabling the consumer or the patient to use a tool they trust, right, to help make those decisions. Because it is an inconceivable ask to do right now as an individual, right? Like the consumer with the cape it doesn't exist because it's quite impossible to figure out exactly what's important and what's not. Even that's true on the enrollment end of insurance often, right? It's hard to figure out what your options are when you're signing up for it, much less when you add the variability of what things that may or may not happen in a certain care episode.
And if you could indulge me just real quick, I think, what we may get to is that the frustrating thing, to put my Debbie Downer face on here, is that we see folks who are wedded to the old model or the old way of doing things, trying to frustrate this, consumerism that's rising up, and the tools that will empower that consumerism, like Anish, what you talked about with the hospital, technical glitch, which wasn't technical or a glitch, but an intentional act. But compared to where I think people want to go with No Surprises and the real-time benefit tools, but even those, are frustrated by some technical challenges, including lack of eligibility, which drives individual information, right, at that, singular consumer level, to be able to say, this is where I'm at in my benefit, this is my formulary, this is my cost sharing, what's the best choice for me, right? And really driving it to the micro level versus having a macro disclosure of 230 or 70 or 300 prices that just kind of live out there in the universe.
Yeah, and so Joel, what I'm hearing you say is price is nice, but also figuring out what individual is associated with what plan and is what eligible for what is a whole nother problem. If we don't solve both of those problems, one's going to be a rate limiter to the other.
Got to make it actionable.
Yeah, and the Christmas tree ornament here is that buried in the surprise billing legislation is a requirement for every plan, including government-sponsored and, for the first time, ERISA plans, must disclose provider directory information under significant penalties for inaccuracy. So there's a lot of goodness in these rules that people, when they look at this and say, I have to go live by January, 2022, this is insane. But the good news is, let me do a couple more things. There's a question in the Q&A that said, hey, this is a nothing burger in Chicago, something to that effect. Here's what I would say. When it's simply hospitals looking at each other's shoulders, deciding, are we going in, or are we not? And sort of looking at each other, getting attacked in the news for having, presented bad information. That's one-dimensional chess. Are we in? Or are we going to eat the penalty? Now we've just ratcheted up the chess, because now the health insurance price transparency rule kicks in by next January. The plans have to publish their negotiated rates. So you would want the hospital website to say, Plan X is paying us Z for this service. And how embarrassing would you look if the plan says our negotiated rate is Y? You do not. So now you can't hide, Joel. You can't take the option of, I'll just eat the $100,000 penalty, whatever it is, because it's going to be out there anyway. So now what are you going to bet that the plans don't comply? Compliance is like plan job number one. These plans don't want to be out of chief compliance officer. You're the king, you're the queen. So, in my opinion, this information's coming, and it's worth a word about what CMS has done with ERISA. It's labor CMS. The price transparency rule is a pan healthcare insurance industry rule. Of course, the only ones that are exempt are the state, single state, governed by only your state. But, you all can, hide if you want, but the world is changing. The interesting thing is the plans have to publish 3 files: in-network rates, out-of-network counts. So now you're going to see, oh, this plan has a long history of paying out-of-network fees to Dr. Jones. Hey, patient, if you want to go to Dr. Jones, get the heck out of that plan, okay? Because you're going to get stuck with some of this surprise billing hassle, right? And oh, by the way, the third, of course, is the drug pricing. This is exciting to me when you push the provider systems, then you push the plan systems on the exact same source of truth. Then the third leg, and forgive me for filibustering because we should get to real-time benefit check, but the third leg, and this is it happens at the exact same time, CMS is launching a direct contracting program. And that direct contracting program is giving a primary care doctor the full budget for these services. So not only is the consumer not going to have to wear the Superman cape on his or her own, or hope that their doctor, who naturally is going to get information from Kyle's team, does the right thing with it. There's now another force, which is those direct contracting entities, of which the first 50 have already been published. It includes, big networks like Aetna from CVS, and, some of the cool Oak Street and the Agilon and the Village MD, all these cool networks that are coming out in a neighborhood near you. They're also explicitly encouraged to negotiate provider discounts. So Kyle, what are they going to do? Are they going to take a generic price discount on Band-Aids? No, they're going to use these same shoppable services and say, you know what? I do want to give my patients the best advice about where to get a knee or a hip replacement. So I'm now another demand signal for this information to be useful, in my opinion. So that's why you see all this excitement coming into the years 2021, 2022, because you've got a force to disclose and an incentive to get clinical networks to be more active in helping shop for higher value care on behalf of the individual.
That makes total sense. And one thing, you both mentioned briefly the timelines. What risk do the timelines create, though? Like this, I totally believe in the vision you're laying out, Anish, and maybe Joel, you're the right one to start here, given you may be hearing some of this feedback directly. A 1/1/2022 deadline for a health plan feels like screaming fast, based on my experience in this industry. Are they gonna, line up all the wood behind one arrow and get it done? Are they gonna combat it? Is it do those aggressive timelines help us get things done, or do they create, do they gum up the gears in some way?
I think so the danger of the timeline is that it will get pushed back, that you will see a delay in implementation. And I think what we've seen, particularly around the information blocking rule, is that the pandemic has been used as an excuse to not to push things back, right? And that's legitimate. And I want to be fair here. Like, hospitals are treating COVID patients, and maybe not focusing on complying with how data is moving around the system. But the danger is that those things would be used as excuses to not do the right thing, or to do something like what we saw on the hospital side to kind of thwart the intent of Congress and first the Trump administration, now I believe the Biden administration. So on the upside though, having an aggressive timeline means that people are actually moving towards compliance, right? Like, and on the No Surprises Act, we've got 2 tranches of regulations, one coming out in a couple months, in July 1, I believe, and the second round coming out at the end of the year. And people go, holy, you know what? We can't make that. And I say, why not? And if you let me just tell a story here for a second. Back when I was the staff director at Ways and Means Health, we were doing a markup on the precursor to the HITECH Act. And there was a young congressman in the room. The Republican members were meeting in a closed door room to talk about how they were going to handle the markup strategy. And this young guy said, I want to offer an amendment on transparency. And my amendment would require disclosure of prices and to a consumer, upfront, and make the EOB understandable at the back end. And we want to disclose quality and charitable care. And this was 2005. Okay. So, these issues have been around a little while.
Joel, who was that? Can you disclose? That's awesome.
I will get to that in a second. So Nancy Johnson was the chair of the health subcommittee at the time. And I love Nancy Johnson. She's a wonderful member of Congress, but she basically said, maybe rightly at the time, she said, we don't have the ability to access the data, nor do we have the technology that's capable of accessing the data in a way that would make this easy to comply with. So I understand your intent. I'm pro-consumer. I want people to have information on price and quality and value, but not yet. And that was 2005. And that young member of Congress was Paul Ryan, who became the Speaker of the House.
Wow.
And he was prescient. And that was just 16 years ago. And now we're standing at the precipice of we have the technology, we have the data, but unfortunately we have a cadre of actors who is unwilling to give up the data to advance a more valuable healthcare system. But on the other end, we have a whole cadre of actors who are just chomping at the bit to say, yes, this is next generation healthcare. Let's open this up. And the rules create those opportunities to open this up and to really make this transformative.
Yeah, absolutely. And
you by the way, thank you for sharing that story, Joel. There's a lot in Washington that is hyper partisan, and often just you're on this side or that, and you can't break through. Fixing the healthcare system has a lot of politicization. Modernizing and transparency and interoperability are right down the fairway of collaboration. Let's get the technical matters addressed and let's move the ball down the field. Here's my statement about the timeline, which is the patient API rule introduced, I think it was May of last year, finalized, I should say, May of last year, gave them a year. It was January 1, and then they got a 6-month delay in the process. Here's what that signaled. Write the check, do the project. I think there's been $1 billion of investment made in the last 12 months to API enable health plans. And, I work for some of them, Humana, others. They're live now on their patient access API now, in the middle of the pandemic. So I'm going to tell you that once you get a deadline, like, and the surprise billing thing is not an executive branch, kind of approach. This is Congress has been talking about surprise billing for a very long time. And this reflects bipartisan consensus, like literally the best of both sides. And they agreed enough to put it in a must-pass bill. So to me, this is if I'm in the industry, I'm writing implementation checks to meet these rules. Whether I need a delay for a few months because it's really, really, really hard, that's a separate matter. But in my opinion, this is the biggest opportunity that I've seen. Now, here's the big shoe that needs to drop. Right now, to cluster claims data into this good faith estimate, you need to group the claims. And by and large, our industry has proprietary groupers in order to make this, to bring it to life. So there's one theory that we will have a competitive dynamic where people that believe in vendor A are going to build a set of standards on the data model with vendor A, and people who believe in vendor B are going to have a standardized data model. I think the decision that we all must face is whether we use an open source method to demonstrate what the good faith estimate should be, regardless of your vendor. And of course, I have a dog in this fight. I've signed up for as you know, CMS funded in the Affordable Care Act, something called the episode grouper for Medicare. And that's an open source, federally funded. Brandeis was the research institution that had the contract. And they've made that underlying technology publicly available. There's a nonprofit they've stood up called PACES, Care Journey, where I run. We are a member of the PACES community. Anybody can be a member. This is not a secret society that requires you to have some kind of password. This is an open model, and I'm encouraging as many people as possible to develop those good faith estimate data models using an open technology for grouping claims. And if we do that last leg, we'd have a common language. And Kyle, at some point, you're going to get us into the discussion about where the APIs fit and real-time benefit checks. So we'd have a transmission method on an open data model to liberate this information where it's needed most. That's what I'm hopeful for.
Yeah, absolutely. And the life cycle of a lot of this has been lived in cures, and we just passed a really important date in cures. So what do we see in that process from start to finish that we could potentially learn from on some of the other newer efforts?
Yeah, Joel. Yeah, you go first. Yeah, how are people handling this April 5th launch date? This is the big event.
Right.
Big event. We got the enforcement folks out and in droves, right? They're coming into all our living rooms to see if we're blocking information. Information blocking, it's incredibly complicated. First of all, it is going to be difficult to comply with. There's a lot of wiggle room, I think, in some of the exceptions, but it's important in the sense that it really tried to get at this. I called them a cadre, but there's a lot of people who are holding on to the past and holding on to the data because they've made money on that for a long time, and they believe in that system. And there's a different group of actors who are really trying to capitalize on the open data movement and being able to really make a run at things by using data in ways that really generate real value versus having closed systems. So the info blocking rule basically was included in 21st Century Cures Act. It's something I worked on a long time. 2011, I remember me and Andy Slavitt went in and met with Dr. Blumenthal, who was at ONC at the time. Andy was in the private sector, and we said, there seems to be a problem. This hospital can't exchange radiology with the ER and vice versa, and they're both using an Epic system, and we don't really know what's going on here. And it turned out it was a closed API, and it was just a custom install basically. And Dr. Blumenthal graciously said, we'll look into it. And The challenge is that, there was a lot of issues around info blocking and these walled gardens. And it took an act of Congress actually to finally, 5 years later, to be able to produce a rule of this scope and magnitude to say, no, in programs where taxpayer dollars are on the line that are designed specifically to require the exchange of information to improve care outcomes and to empower providers to deliver care to patients, you can't block information unless you meet one of these 8 exceptions or categories. And those categories are designed, I think, they tried to design them in a narrow way to say that, if we fall in here, if the request is unreasonable, or if it violates HIPAA or some other category that law, that you don't have to share the information. A challenge I think that we have here, and we'll get to the privacy rule, is that this requirement is layered on top of the existing HIPAA system and all of the things that come with HIPAA. And HIPAA, obviously, Anish did a lot of work on this during the Obama administration, where you have patient-directed exchange and you have access rights to your information. So the combination of the info blocking rule and the HIPAA rules really create a powerful framework to be able to say, as the consumer or the patient, I want to direct, and you can't block information flowing to these trusted fiduciaries or navigators, as we talked about earlier. That creates an incredible opportunity to generate value at the consumer level by presenting information that is very specific to that patient's position in their benefit, in their care, et cetera, so that they can make better informed decisions alongside their provider, right? So we're empowering providers, we're empowering patients, and these 2 rules are really working in concert to provide the data necessary to be able to do that.
I want to just take a technical deep dive for a millisecond, because it's critical to understand why it has created the benefits that we need. When you believe that the consumer has the right to access their data via an application of their choice, it creates a significant pressure point on whether or not the data holder can charge to get access to the data. And here's why. When I have your comment about the lab system and the imaging system and the ER, whatever the scenario was, the reason a proprietary API is the default setting is, this is my database. I built the data model. If you want to feed data in or out, a human can enter it or a machine can program it. God bless America. That's how the entire IT data infrastructure for corporate America works, okay? And it's a proprietary system. If the law says that the consumer can tap that database, you either have to open source your database and give away your intellectual property, because you can't charge the consumer to license. All of a sudden you're putting an intellectual property license on my health data, which is like a no-go, right? You can't do that. Either you open source your data model, or you agree to convert the data from your proprietary model into something that is open. And the industry has absolutely consolidated around the FHIR data model. So as long as I can convert the data from my proprietary system into FHIR, then I can trade that information to consumer apps where there's no intellectual property contract. I don't have to sign a license. Now here's the issue, here's the rub. Once you've built data in the FHIR format for a single patient app to consume, there's no technical reason you can't offer that by contract for B2B use cases, or Kyle's app that wants to be able to run inside the EHR. So that is the key in my view. And I think, Kyle, maybe we go from here to your future, because that seems like the path to go.
Yeah, let's talk a little bit about some of those reasons for optimism, because I think real-time benefit has been a good example of when this can work well. And there are opportunities to do better and different. But again, just to touch back where we started, right, is that the ideal state is rules get enacted, technology meets the mark on that opportunity, and you deliver value at scale. That's how we're going to impact the system and the cost of the system. So the way this worked before real-time benefit is that flat files moved from entity to entity. That means a list of people and their associated eligibility and formulary information had to go from one entity to the next, somewhat manually. Even if it were electronically, it had to pass from entity to entity to entity to entity and then be downloaded by the EMR system in order for that information to be there when a physician was selecting a medication on behalf of the patient. And what that fundamentally created was a data lag, information that was often out of date. And the core problem that created from a provider perspective is just they stopped trusting the information, so they stopped paying attention to it entirely. It became something that just wasn't valuable to the decision-making process for many providers because they'd lost faith in whether or not that was actually going to be reflective of what a patient would face at the pharmacy. So real-time benefit comes along and provides real-time, patient-specific, and pharmacy-specific information around that price. So the big change is, if a patient has other activities in flight, if they've already pended a prior auth, if they've already moved through some portion of their deductible, if they're in a different coverage phase, those things are all reflected now in a real-time benefit tool so that the physician can trust that information more. They can get real-time patient-specific and pharmacy-specific insight into the price of that medication and have a conversation with the patient as a result of that. And alternatives come through that are in alignment with the formulary and the preferences of their health plan. And those might be a different destination for that prescription or a different medication that may be considered as a result of that formulary design. That's all real-time insight that wasn't available before. So the progress here is that we've been working on this for a number of years. We've more than 7 years on this problem, right? And there were ambitious, forward-leaning health plans that we work with that were driving this work, and PBMs that were driving this work, and they saw the value in it. But really, the RTBT rules created a lot of momentum for that and really moved the industry forward and sort of created this call to action for those that may not have, for their own reasons and for their own preferences, have been pursuing their work otherwise. And so it really catalyzed the industry around solving a discrete and specific problem. And I think it's delivering value at scale now. I think there were 72 million or so real-time benefit checks last year. And that's probably a doubling of the year before. So it's been a great opportunity to celebrate when the policy drove, technology momentum, which drove some value at scale. And we're proud to have been a part of that. So as we get into the future, what's next in our ambition to take these silos that are, the data is now more available and liquid to patients. The technology opportunities are out there for companies to come be the trusted steward of this information. The policies are sort of setting the foundation. What do you all see as the future here? What do you anticipate in the next 12 to 24 months as a result of this activity?
Yeah, we may have jumped the gun on the future by talking about that a little bit on the previous context for the policymaking, but I'll just reiterate, and maybe Kyle, you might take a minute to look at some of the technical questions that have come in around the pharmacy's role in prior auth and so forth. But I'll just take the first stab, Joel, if you want, which is to reiterate, I think the voice of a new actor in this transaction will be heard. And that will be this health information fiduciary that will, in your example, Kyle, the 72 million transactions, those went to the physician at the point of care, just to kind of get to the detail. I forgot if you have a word or two about how often they change their mind. I don't know if you've shared that in that riff, but it's not insignificant, right?
It's meaningful, yeah. It's as high as 15 to 18% of swaps. Yeah.
So already there's evidence, in my opinion, more evidence of shopping when you provide the data to the patient through a trusted fiduciary, in this case, the digital Hippocratic oath, right? And so that number, and by the way, I didn't mean to put you on the spot, Kyle, but as we get into that number kind of becoming more widely understood, it is going to blow people's minds who are used to saying it is a nothing burger, no decisions change. I remember vividly the Pennsylvania research study that said, we're literally telling you, patient, that the doctor, the heart surgeon you're going to at the hospital in which you're going will lead to you dying more likely than if you go here. And it still didn't change referral patterns. I'm over exaggerating and going by memory, but basically that was the story. It was like, from the 90s. So your statement of minimum double digit changes, presumably, I assume, to lower cost, still effective drugs. You didn't say that, but I'm going to assume that that's the case. It is evidence that a real-time trusted broker who's engaging in these conversations, and maybe it only can be the doctor, and maybe the answer is all this has to be presented to doctors in the course of their work, and maybe they're going to say, I don't want it. Maybe it's the care manager.
Yeah, I think
maybe it's a caregiver for the family, someone who's on the team that's organizing for this, and that's the new thing to look for. They're not knocking on your door, Health System X, but they may be the one who's crawling your website to pull this information. So I think, Kyle, why don't you answer whatever questions there were on there, if you don't mind, and then Joel, we want to get back to the topic.
Well, let me expand a little bit on what you're saying too. First is that there's really the future for real-time benefit is around specifically what you're mentioning, is it's engaging the care team. Is that there are, a lot of these high-cost medication decisions happen before the patient ever walks in the door in a care planning meeting, or they happen after the patient walks out the door where they're trying to resolve a prior auth or trying to resolve some other friction associated with that decision. And it's really both engaging the care team, which expands beyond specifically the prescriber, and engaging the patient in a lot of cases, right? Like we want patients walking in the door empowered with knowledge of what those decisions might be, so that they can consult with the provider. Because the one thing that we know is true is, and I think your example about referral patterns sort of underscores that, is the personal relationship that patients have with their physician is the most trusted relationship they have in their healthcare lives. And if we can empower those providers with the information they need, empower their care teams with the information they need, and then have patients starting to use these types of technologies to make better decisions and empower themselves, that's sort of the ideal state. Now, one limitation to that is around that eligibility information. So more availability, even within the real-time benefit rule, to know that Kyle Kaiser's a part of a certain health plan and a certain formulary outside of some of these native EMR workflows is a huge need and a great opportunity, because those are the ways that we can go after not just sort of all transactions on the whole, but there's really high cost transactions that are happening out of the view of the ordering workflows at times. So how do we help influence those decisions? Because I think those are things everybody's raising their hand to do, right? If you're on a high cost specialty med, if you're going through a complex care episode, we want to make sure we're meeting those decisions wherever they are, rather than just deciding that the e-prescribing flow is enough. Because I think there's a lot of opportunity left ahead of us if we think it that way.
Janice has a question that you may or may not want to tackle right now, but I would recommend, this is a great research topic for you, Kyle, which is, for the doctors who switched 10, 15, 18%, did they compromise quality by picking a horrible alternative because it was cheaper? And is there a way to judge in the feedback loops the decisions that are being made to gauge whether they are truly a better choice for the individual? I don't know if that's on your radar, if there's a clinical review committee to look at these actions to see what happens. I'm curious.
No, it's a great question. And
it's really Janice's question. It's not mine. I'm just relaying it.
Well, great question, Janice. I think there's an opportunity within real-time benefit is that there's an enormous amount of clinical rigor that goes into a P&T process at a health plan. They're not just sort of willy-nilly picking things off the shelf and putting them in as alternatives, right? There is a rigorous process, and it's just making those preferences visible to the prescriber. Now, I think we all agree that the prescriber at that moment is going to have the most clinical context. They're going to know the most about the patient. They're going to be the one that should be making that clinical decision. And I don't think I haven't found often that the alternatives are a compromise to that decision. It's really just saying, here's the information that's available based on the payer's understanding of clinical efficacy and quality and value, and injecting that into a clinical decision-making process that where it may not have been present before, right? It's that, there are a half a dozen drugs in a specific class, and there might be some preferences around that just the physician's entirely unaware of, and that might be different from payer to payer. So it's really just connecting the dots and empowering those providers with new information, not expecting them to make, clinical decisions that wouldn't be of the same standard or quality otherwise, for sure. It's a great question, though.
Yeah, and I think, Kyle, just to add to that, I think that, as we see with real-time benefit tools, there's a piece or two missing. But as we move, these tools more into like a central component of a care management strategy, right? That filling in those gaps or those pieces are going to be pretty important. And I think to this question, as we move, beyond just the drug world into services, say for electronic prior authorization, we really are going to need to layer in quality measures and data, and perhaps even charitable care policies to be able to direct people not just to the lowest cost, but to the best option.
Yeah, and there's a ton of opportunity just in site of fulfillment or site of care, right? Like not even asking the physician to make a different clinical decision, but just providing information so that they understand the differences associated with going to pharmacy A versus pharmacy B, or going to home infusion option A versus home infusion option B. Those are just things that aren't visible without tools like this. And they'll certainly impact quality, because I think when you do that, when you send it to places that the patient's more likely to afford, they're more likely to, follow that care regimen. They're more likely to be adherent on those meds. They're more likely to have a better outcome overall, because we've connected dots that couldn't be connected before.
And that may be getting to this Larry McNutt question about whether or not minimal compliance will kind of limit the benefits. And I do wonder, as we get, I don't know if there's another metric to track here, Kyle, but complaints to the physician's office because the meds are too expensive at the point of pickup. I don't know if that's a thing or if there's a way to track that, but I don't know, anecdotally, I hear from doctors that like more than half the calls into their office are drug pricing related. And I don't even know if that's a survey you offer to get feedback on, hey, are you seeing a reduction in complaints? Because maybe the feedback loop of this, hey, look, the water is warm. This price transparency step that I'm going to take is going to actually make it better for me to be a better doctor. And I don't know if that's a thing or not, but I'd be curious to get your feedback as to how to measure that.
Yeah, absolutely. I mean, to your point, I think I've read 65 million hours spent a year on the phone, reworking prescriptions back and forth between pharmacies and clinical settings. So a ton of opportunity to do that differently. And I think we are seeing, the right decision happening the first time. The one thing we don't talk a lot about as an industry, we spend a lot of time talking about transmitting prior auths. Well, there's a lot of opportunity to avoid them in the first place. And I think you want to, first empower the physician to avoid the prior auth in the first place. And then if the clinical decision leads to requiring one, then certainly we want to smooth the path to that happening as quickly as possible. And there is, opportunities to improve that process. Even today, there is adoption on electronic transmission of prior auth. A lot of it's still retrospective, which means a lot of it was triggered by a denied claim. Well, if we can get the clinical decision right the first time, we can get the prior auth avoided, or we understand the requirements of that prior auth up front. Would it be better to smooth that path and empower the physician and the patient to make a different decision that doesn't require that sort of administrative cost? They're entirely avoidable in many cases, and that's the opportunity.
We're reaching the end of the hour, but we're communicating right now, Kyle, with this audience to say, step into the pool and then engage in a way that takes all these potential benefits and brings them to life by building upon Congress's actions. Joel, I hope they don't call you to say, hey, can you help us overturn these horrible things because we want to go back to the way they were. I hope you won't even take them on the offer, Joel.
I decline that offer.
You'll decline that offer. God bless you. Right? Come on in, people.
That's right. It's there's opportunities to drive a ton of value, and it's maybe just as much effort to resist as it is to invest, and so the opportunity to invest is.
And Anish, I think to your point, there's a weight of history here where we are going towards more transparency, more empowerment, more use of data to improve value. And I think people who are pushing against that wave are going to be really unsuccessful.
Absolutely. Well, everybody, thank you for the time. And Sean, I don't know if you want to take us out here, but we do appreciate the discussion. And Joel and Anish, thank you for joining us. This was time well spent for me. I hope you all agree.
Yeah, just want to mention too, there are dozens of questions. We weren't able to get to all of them, but the RX review team does have them and we'll follow up. Also, there's a survey we'd like you to fill out, so please give us your feedback before you exit. And a big thank you to RX Review for making our session possible today. And thank you to Kyle, Anish, and Joel. And thanks to all of you for signing on. Just a reminder, you'll receive a link to the webinar recording when it's available, so you can view it again. That's going to do it for today. Thanks again for everyone's time. Have a great day.